Thanks very much for the opportunity to present today. I suppose this presentation is following on from the series of talks where we've had experts in palliative care, infection control, public health, and a range of individuals, respiratory medicine, talk about COVID and where things are at, and how, if you like, informing us on what COVID infections look within the nursing home setting and how it may transpire. I suppose, unfortunately, at the moment, it's becoming clear that COVID has and SARS-CoV-2 has really exposed these fractures in our society and our healthcare services into those areas that perhaps didn't have the adequate resources, didn't have the adequate defences in place to be able to respond as quickly as some other areas, and those include our nursing home sectors, our ID facilities. I think things in and around domestic violence and things like that. The nature of the measures that have been enforced upon us and the nature of the healthcare crisis that we're facing has really gotten us to reflect on where everything is and on how we've delivered care and are there better ways of doing it. I suppose the flip side of that is it has been an incredibly enriching time to be working in the health service, because we've managed to do things and pull people together and have, if you like, shore up so many of these fractures as we've gone along, and it's probably led to the development of cooperation and collaborations that were probably badly needed for many years, and it certainly, I would hope that it continues beyond the COVID era. The main reference guide, just to start off with, is the updated guide that came out last Friday. It may even be updated after the NFET meetings this week, which is the one that's up on the HPSC website, and that will talk about things like staffing levels, PPE availability, testing results, who to test, palliative care access, occupational health and advice, and those are all of the recurring issues. For today's talk, I'm really kind of just going to look at some of the information. There's a huge amount of fear, there's an awful lot of media coverage, I'm sure everybody has heard it, and one of the main things that propagates fear is the absence of some of the facts, and some of these are facts that we're very familiar with, and others are facts that maybe get hidden sometimes in the detail. So our total COVID cases as of yesterday is over 12,500, 444 deaths, 82 is the median age. That means that half of the people who have died are over the age of 82. We have about 580 nursing homes. It's variable depending on criteria, but we have about 580 nursing homes in Ireland, and currently about a third of those have an outbreak. That means 2/3 don't have an outbreak. We have about 31,000 people living in residential care, long-term residential care facilities in Ireland. And of the deaths so far, 245 of our 444 deaths have been in nursing homes, and that equates to around 55%. So that's kind of a snapshot of the activity. If we look at the international experience, a huge amount of this is being covered in the media, and I've just kind of, so we can say in the US, in Spain, in France, in the UK, right where COVID, in Italy, wherever COVID has struck, care homes have been disproportionately impacted. And the media coverage has very clearly focused quite quickly on the impact of COVID in this sector. This is data that was published on the 12th of April from the London School of Economics, and I've given the link to this report at the bottom of the page for people to have a look at. And what it does is it goes through the COVID and COVID-related deaths in long-term care facilities in other European countries. And what we can see is really between 40 and 60% of all COVID-related deaths in all these European countries, including Ireland, is in long-term care, older persons residential facilities. So what we're experiencing in Ireland is actually what has been the international experience. And I think that's very important when we're talking about it in the context of our responses to the media and what's portrayed in the media, that this is not a unique, scenario that we find ourselves in Ireland. The Belgian Health Ministry has published quite a bit of detail as they've been monitoring their figures as they've gone along. 90% of all Belgian care homes have at least one confirmed case of COVID-19. So when you compare that to our 1/3 at the moment, it can give you an idea with regards, how we determine success, but also that there's certainly no room for complacency in this regard. there has been, I think one of the things is, at the moment in the health service, each day feels like a week, each week feels like a month, and each month feels like a year. And you can sometimes feel that you've been living with the coronavirus for years and years on end. But in reality, this is a scenario that has evolved very rapidly over the last 2 to 3 months. There is only really 3 epidemiological studies which are quite small, which have looked at COVID in nursing homes and the impact of COVID in nursing homes with any great detail. All 3 are US based, and all 3 had an involvement from the Centers for Disease Control and Prevention over in the US, so have high validity, but are all on isolated pockets. The first study was a study of the initial outbreak that happened in King County in Washington. And they took a first index case on the 28th of February and followed it forward, looked at all visitors who came to the facility, looked at all staff members, and looked at the factors that propagated an outbreak, which went from 1 resident in 1 facility to 164 impacted residents or impacted contacts with COVID-19 2 weeks later. And what they found of those 164, there were about 40 deaths, including 1 visitor. About 101 of the 165 or so were residents in the facility. Another 40 or 50 were staff in the facility. And then there was also about 16 or 17 visitors to the facility who contracted COVID from this first index case that they were able to match. So I think this kind of goes with the whole social distancing and flattening the curve message, that 1 index case propagates to many other multiple cases over a few weeks. But their findings from this particular study, when they looked at the key factors that fed into the outbreak, they identified staff who continued to work who were symptomatic. They found staff who worked in more than 1 facility. They found inadequate familiarity with and adherence to PPE, challenges in implementing proper infection control practices, including inadequate supplies of PPE and hand sanitizer, delayed recognition of access due to a low index of suspicion, limited availability of testing, and difficulty identifying persons with COVID on the basis of signs and symptoms alone. I'm sure this all sounds very, very familiar to many people who are on this call. These are the exact same challenges that we have been finding in our own Irish scenario. The second report then looked at asymptomatic. So they took 76 residents where there was 1 resident positive. They went and they screened all the remaining 76 residents in a nursing home, also in Kings County, a separate nursing home. They found that 30% of residents tested positive. Only 10 of those 30% had symptoms. So 50% of over 50% of the residents in the nursing home who were positive on their swabs had no symptoms. Now, what is somewhat reassuring is that within a week, the majority of those had actually developed symptoms, but it just goes to show that asymptomatic carriage is a significant feature in the nursing home setting. Eventually, many of them will develop symptoms, but there is at least that 1 week period where at least half of these residents had asymptomatic carriage, which explains the severity of the outbreaks when they're arising, because where we're seeing 1 case, we're often seeing many. The next epidemiological study, which was interesting, was on an assisted living facility. And what was interesting about this is on the basis of the previous 2 studies, they expected to see a large outbreak where they had initially 4 cases come in from unassisted living facility, and they went screening everybody. They initiated very, very prompt social distancing, and actually what they found was with controls, they only ended up with 3 out of 80 residents testing positive over the next 2 weeks, and 2 out of 62 staff. And their key finding from that was because of the nature and the environment of the facility, where they had own door apartments and there was less frequent healthcare workers contact compared to the other 2 studies. So we're really getting to see a sense of the key public health and epidemiological factors that lead to propagation of this virus within the setting. And unfortunately, one of it is inherent in the design of the facilities. Just going to briefly mention some of the cases, because I think it's probably helpful for people in residential care to know what happens when people are coming in from nursing homes to the hospital. First cases, these are not remarkable cases. These are pretty much reflective of very much the standard case that we've been seeing of individuals with COVID. The first gentleman is a 79-year-old male, nursing home resident for 3 years, had a fall in the nursing home on the 14th of March, dry cough for 7 days at that stage, has an extensive history of past medical history of multiple comorbid issues and vascular dementia, and would have been one of those gentlemen who walks with purpose. When he presented his saturations, his oxygen sats on room air were 91%, but they were recovered to 96% on 2 litres. His respiratory rate was a little bit high at 22, but otherwise things weren't so bad. But his CRP was quite elevated at 87, and he was lymphopenic. Chest X-ray was, essentially clear. He was swabbed for COVID on the basis of his respiratory symptoms at that stage, in line with the advice at that stage. And the issues within the nursing home had been that he had been walking around the nursing home. He was admitted having had a fall, and there was now other residents, and within 24 hours, other residents adjacent to his room became positive. He had a very fluctuating course where he had a fall on the ward. We had to put a one-to-one special with him. He developed delirium superimposed on his dementia, which is very much a mixed pattern. His CRP went up. We commenced him on intravenous antibiotics because the CRP wasn't settling and it was going up. He had somewhat of an improvement, and we thought that actually things were beginning to stabilize. About less than 10 days into his admission, he had a very abrupt decline. He had a massive increase in his oxygen requirements. His saturations dropped 80% on 10 litres of oxygen. His temperature went up, and he had really been relatively afebrile until that time. He developed ribers, and quite quickly he went into a state of severe respiratory distress, requiring palliation of those symptoms, and he unfortunately passed away within the 48 hours after that. The second case is an 86-year-old gentleman who came in from a nursing home where we knew there was confirmed cases of COVID in the nursing home. He had had a cough for 5 days. He had been pyrexial and tachypnic in the nursing home, their main issue was that they felt that his symptoms were beyond even the nature of other people with COVID symptoms in the nursing home. He had quite significant dementia and required support with most of his ADLs. When he came in, it was quite clear that the main issue with him was that he was quite dehydrated. He had very dry mucous membranes. His chest was relatively clear and there was no consolidation on his chest X-ray. His CRP was only 39, but he was quite dehydrated on his electrolyte panel and on his renal profile. He was COVID positive too, and we managed his acute kidney injury, where he got slow intravenous fluids. He was weaned off his oxygen, and I suppose the good thing with this gentleman was, like many of the cases that we have managed within the hospital or within the nursing home, with actually minor supports, this gentleman was able to recover quite well and was discharged back to the nursing home within 3 or 4 days. And we had a discussion with this family regarding the ceiling of care and the future discussions about hospital transfer and things like that. Earlier, I think we were one of the first areas, and we'll be able to show some of the details where we had a clear line of sight on 2 or 3 nursing homes with outbreaks. So quite quickly, we, as a hospital, identified the necessity for a team to target this group. The team includes an advanced nurse practitioner, Claire Noonan, who all the directors of nursing and GPs in the nursing homes have talked to regularly at this stage. Myself, I'm one of the geriatric medicine SPRs. And essentially it's about linking in with our palliative care colleagues, or the GPs, directors of nursing in the nursing homes, public health doctors where necessary, and most importantly our CHO services. The first step when we set up this multidisciplinary rapid response team was to get a register of contact details for all the directors of nursing and GPs or medical officers in the local nursing home. After that, we gave them contact details for an extended hours contact phone, which all of the team carry. And we have arranged very regular Zoom calls to review patients or to discuss cases or to discuss outbreaks in the nursing homes as they've happened. We've also developed an in-reach service, so we're the only service at the moment who's working across COVID and non-COVID areas. So all nursing home residents or residents from intellectual disability services are coming in under our team at the moment. And we've also established an ED pre-alert system, so that if somebody is coming in from a nursing home, they contact the ED, and during working hours we'll see them in the ED in the hope of being able to address any issues there and send them back to the nursing home. The link with the CHO team has been really essential. We have the daily information bulletin on all new nursing home outbreaks in our catchment. That includes suspected cases, positive swabs, pending swabs, deaths due to COVID, staffing impact, and all of that information is fed through to me on all of the nursing homes that we're looking after on a daily basis. We have a twice weekly teleconference that's chaired by the Carol Cuff, who's the CHO and social care lead for CHO7, and that involves myself, geriatricians from the other acute hospitals in our CHO, infection prevention control, and the nursing and management team, and reps from public health. And that really talks about PPE issues and any other issues that are arising with regard to staffing in these nursing homes as it's happening. Just to reiterate, under the guidelines that were brought out last Friday, an outbreak is classified as a single suspected case or positive swab in either a staff or a resident. So it's a very low threshold now for defining an outbreak. I'm regularly asked, should everyone be swabbed? And the current advice is that after you have 2 to 3 positive swabs in staff or residents, you presume any individual with new symptoms has COVID. But I suspect as the capacity for testing increases and nursing homes are in a position to perform their own swabs, then this advice may change, because there's no doubt about it. We need to, similar to the national response to COVID, we need to be testing in our nursing homes, residents and staff. Just to give a snapshot of our current team activity, we've regular contact with 14 nursing homes, 13 private, 1 public. It's over 1,000 beds. 10 out of the 14 nursing homes we're in contact with have confirmed COVID residents, or residents who are with confirmed. So that will give you an idea of the level, the extent of the outbreaks. And of those without confirmed COVID, only one of them doesn't have at least one suspected case. So all of them, bar one, are fitting the criteria for an outbreak currently. There's been a few recurring themes that I thought we would just run through very quickly before we get to the questions from the rest of the panel. And it's really around presenting symptoms of COVID. So I think most people are very familiar now with the dry cough and fever. But actually what we're seeing in this, and it's been reported time and time again from nursing homes, is the atypical nature of presentations in this population. And indeed there's a paper I've referenced here from a Toronto group who talk about the observations of presentations in older patients. Only 20 to 30% of older patients present with the fever, and then dry cough is very much a late fever feature. Diarrhea, nausea and vomiting, we are getting that, I would say, at least 25% of people or individuals in nursing homes are reporting diarrheal outbreaks for about 2 days ahead of having defined COVID cases. So there's no doubt that compared to the Wuhan cohort, we're seeing more GI symptoms in the group that we're looking after. The threshold for diagnosing fever should be lower, so looking at 37.5, or at least, or in other circumstances, just an increase of 1.5 degrees Celsius from their usual temperature, because I don't think, as we said, fever is not reliable. And older adults may present with very mild symptoms that are disproportionate to the severity of their illness. Almost to a facility, we have had a conversation with the directors of nursing or GP who report an unexpected death in the preceding 2 to 3 weeks, and their suspicion is that that was their first case of COVID, where there would be somebody who may have had comorbid illness, who may have been a little bit frailer, but they were not expecting them to die, and they weren't expecting them to die fast. So unexpected death is often the very first case or the very first sign that you may be dealing with an outbreak. For those facilities that do not have a defined COVID case right now, but have had that happen, I think a high level of vigilance is necessary for any other suspected COVID cases. I think the second thing is the disease course is very unpredictable, and Dr. Cullen last week did a masterclass really on the nature of COVID and how it progresses. The key time points are the early clinical response. Universally in the people that we've looked after with COVID, where they have struggled early on and not been able to maintain their saturations, unfortunately it has nearly always, without exception, meant that they were not going to have a positive outcome. And having a high, if you like, lowering that threshold and being very vigilant about timely intervention with palliative care and those people who start off their disease course with high oxygen demands is very important. The next key time point is around day 8, 9, where we see that deterioration in respiratory symptoms. And after that then, even when you're up to 2 weeks afterwards, we see a large number of people who will have sudden respiratory or cardiac decline, like that first gentleman who looked like he was actually through the worst of it and recovering, and he had a very abrupt decline. And those are the patterns that we're seeing, both in older and younger patients. And I think the key reason for doing this, or for highlighting this, is that where you have cases, you need to plan in advance for each resident. And I know nearly all nursing homes have done this at this stage with their directors of nursing and GPs. You need to know the palliative care protocols and have staff trained in the administration of those protocols, so make sure people know where the medications are and how to administer the medications. Make sure the family are aware of the key stages and prognosis. Oftentimes, understandably, when families hear that somebody has an infective diagnosis, they think the longer they hear that they're doing okay, that the better they're getting. I think it's very important that family are aware that for a long period of time, when somebody's had COVID, there is a risk of an abrupt decline. So ensure keeping them aware and keeping them informed that there may be a change in this person's outlook, or there may be a very sudden change in their outlook, so that they're not caught by surprise. And I think the other thing is to start cohorting and to arrange sorting areas in the facility as quickly as possible. So as soon as we see people with mild illness, that's the time to start looking at cohorting patients. The other issue that's regularly asked is, when should we consider hospital transfer? And the answer is, whenever you think the symptoms or clinical course will be improved by transfer. I think we've said several times over these webinars over the last few weeks that the importance of preparing, the importance of reaching out to local clinical networks, be it for palliative care, be it for acute hospital supports, be it for GP care, and know what those pathways are and be able to activate those pathways. I think the questions to consider are, can adequate symptoms be managed and be provided on the site? And that's really about the staff competencies that are available. And we wouldn't expect anybody to be acting outside of their comfort zone. Question, what's the understanding of the family wishes? What were they before they became unwell? What's the goal of the transfer? Are they a candidate for ventilation, non-invasive or otherwise? Oxygen has a very limited palliative role where we're seeing it, and really we're seeing very few residents respond to simple oxygen therapy. So the necessity for oxygen really isn't a good criteria for hospital transfer. Similarly, we've looked at hydroxychloroquine in some of these, and certainly my experience in this population hasn't been positive to date. There is a role for IV antibiotics in people with secondary infection. You would hope that most of them could be provided within the nursing home. Nutritional supplementation is really something in that post-infective recovery stage rather than something for consideration while somebody is actively managing an infection. The other question we're asked is, what if it's a non-COVID related issue? Is it safe to transfer them to hospital? And that's really the only point I'm making on this is to reassure people. We have set up and established, as much as we can do, non-COVID pathways within our acute hospitals to mitigate the risk of individuals from nursing homes acquiring COVID within the hospital. So it is important that we've seen, we have looked after people who have remained in the residential care facility with significant symptoms until they weren't able to tolerate them anymore to come into us for non-COVID related symptoms. And I think it's very important that the message is out. We are open for business to see these people and mitigate symptoms, be it COVID or non-COVID. I thought it was, because the issue around ventilation comes up so often, I thought, just to show what prone ventilation looks like and what is involved. So from the point of view of ventilation, the reason why it's not appropriate in the vast majority of the individuals we look after in nursing homes is because we're now looking at early intervention with ventilation to offer ventilatory support. Looks like it's an imperative, so trying to do ventilation late on doesn't look like it's as useful. The outcomes for people who are ventilated are far from something that would suggest that it's not a cure. In fact, there's fatality rates up to 50% plus out of our ICUs, even in younger well patients, from the rigors of ventilation and ventilatory supports. And we are having to ventilate people for 2 weeks because of the disease course and the sting in the tail of COVID-19. We are often having to ventilate people for 2 weeks, regardless of whether they show early respiratory progress with ventilation. We're having to maintain it just to have precaution against them deteriorating 2 weeks later. So you can see when it's laid out what's involved in ventilation and the rigors of it, why it is that very few of the residents that we look after would actually benefit from or be supported by or be able to recover from such an intensive intervention. And it really wouldn't be holistic, care in many instances to even attempt it. And the other thing is our hospitals in the time of COVID look very different, and it's just similar to our nursing homes in the time of COVID, looking very different, and they can be pretty intimidating environments. The other issue that's arisen is how do we manage somebody who's COVID positive and purposefully walking, and there is absolutely no simple answer. This arises on regular conferences with directors of nursing and GPs. You just do your best. It's a public health crisis, and as such, we're having to give more consideration to the other health of residents rather than the individual as we would usually abdicate. So we do have a responsibility, insofar as possible, to protect the other residents in a facility, especially given the significant impact of COVID when residents get infected. The aim is to isolate everybody for 14 days. If possible, have consistent staff members dealing with the COVID patients. Don't be mixing staff. Identify COVID cohort area very early, and if possible with garden access so that somebody who's purposely walking can go outside. Transiently wandering into corridors and things like that isn't associated with a major risk of transmission, and there isn't any additional cleaning required. So simple redirection and ability to try and maintain that corridor area and try and minimize the contact is understandable and will be inevitable in certain circumstances. And physical restraint shouldn't be used. And any challenging cases where this is being considered should definitely be discussed with the general practitioner or old age psychiatry colleagues who are still very much available for consultation, or indeed with the geriatrician, with the local geriatrician. Just as and I'm finishing up, I think as a few parting points, I think it's really important that we realize there is absolutely no stigma in having COVID in your nursing home. We will discuss things that, ways in which we can mitigate and try and prevent it getting into the nursing home, but it's actually really important that we have a high degree of vigilance, that we engender an atmosphere whereby people are reporting it early and are identifying cases early, be it in staff or be it in residents. I think we have to learn from this. I think when we're seeing the significant impact of this pandemic on our nursing home facilities, there will come a time, it's probably not right now, where we have to reflect on this model of care. And we have to look at what are the lessons we need to learn about how we provide care for this cohort of people. Because there is no doubt about it. When you look at the experience in France, Belgium, Spain, and all of those other countries that I mentioned, it isn't just about actually nursing homes in Ireland. This is about that whole model of care and how we provide care and cohort a vulnerable group of people together that makes it very, very difficult for it not to have the devastating impact it's having in places. And then the last point, and I know I'm speaking to converted when I say this, I've had many conversations with GPs and directors of nursing who've been under huge stress and worked to the level of exhaustion. And in those kind of communications, things can get terse. And I suppose the last message I would have is that we're kind to one another in our conversations, and that we realize that everybody is operating in an incredibly challenging environment. And everybody really is trying to do their best in a very difficult circumstance.